So, Code was envisioned with the purpose to provide a platform for both online and offline by resource people from within our alumni community to share their knowledge and expertise in their respective fields with the fellow Christians. Seeing and hearing from people who have traversed the CDC hallways to reach where they are today would be a great encouragement and motivation for our current students. It gives me immense joy to introduce the alumni speaker for today's code, that is Dr. Aby K Babu from batch of 2006. He's my UG batchmate. Dr. Aby is currently working as head and neck surgical oncologist in Christian Institute of Health Science and Research, Nagaland. After his post-graduation in OMFS from Sudha Rastogi College of Dental Science, Faridabad, and fellowship in head and neck oncology from Malabar Cancer Center, Talsheri, Kerala. So we welcome you, Dr. Aby. So over to you.
Thank you so much. Good morning to one and all. It's so nice. It's like revisiting college again. And thank you for this opportunity and platform to speak for a topic that's very close to my heart. And with no waste of time, I'll go on to my presentation. I'll just share my screen. So is my screen visible? Hello, am I audible?
Yeah, yes.
Okay. So the topic for today is evidence-based management of oral cavity cancer. So we all know oral cavity cancer is an Indian cancer. We have the highest incidence of oral cavity in India because of the habits. Coming over to the statistics, this is the Globocon data in 2020, and this is for India. And these are the 5 most common cancer that is seen in India. And we see lip and oral cavity stand second with a percentage of 10.3. First was breast. Then following oral cavity, we have cervix, lung, and colorectal cancer. Amongst the males in Globocon 2020, we have lip and oral cavity as the most common cancer as the in India, followed by lung, stomach, colorectal, and esophagus. Females, breast is the most common. Then we have cervix, ovary, lip and oral cavity, colorectal. So coming over to the head and neck subsites, when you talk about head and neck, it's a vast region. So we have various subsites into which the head and neck region is divided. First being the oral cavity, then we have the nasopharynx, then we have the oropharynx comprising of the base of the tongue, vallicula, lingual surface of the epiglottis, soft palate, tonsils. Then we have the larynx. Larynx is again divided into 3, supraglottis, glottis, and subglottis. And then we have the hypopharynx, which comprises of the posterior pharyngeal wall, postcricoid, and the PFS. Coming over to the topic for today, so when you talk about oral cavity, one of our favorite sites, what all are the subsites in oral cavity? So there are standard 8 subsites in oral cavity. First being the mucosal lip. Lip is again divided into mucosal lip and the cutaneous lip. Mucosal lip is now a part of the oral cavity. Then you have the tongue. Tongue is divided into anterior 2/3, that is called the oral tongue, and then the posterior 1/3, that is called the base of the tongue or the pharyngeal tongue. Then we have the floor of the mouth, then the gingiva or the upper and lower GBS, the buccal mucosa, the RMT, retromolar trigone region, the hard palate, and the upper and the lower alveolus. What is the etiology for oral cavity cancer? We all know the most common cause being tobacco. And tobacco can be taken in 2 forms, smokeless tobacco, which is also called SLT. And it's important for us to know as academicians, what are the carcinogens that are present in smokeless tobacco. The most commonest being, there are almost 70 plus carcinogens in the literature. The most commonest being nitrosamines and polycyclic aromatic hydrocarbons. In the smoked tobacco, you have again these carcinogens, and along with that, you have the added combustion products of smoke, which are again deadly. Then we have alcohol, betel quid, nutritional deficiencies, vitamin A, C, E, the antioxidants, immunocompromised states, HIV, diabetes. Various viruses have come into the role in the etiology of head and neck, most common being human papilloma virus, which was a major cause for CA cervix, now a major cause in the West for CA oropharynx, EBV virus for nasopharynx, dental factors such as gingivitis, periodontitis, ill-fitting dentures, sharp tooth, occupation, asbestos, textile, leather industry, nickel, coal and cement, prior radiation, which has a role in thyroid carcinoma, atmospheric pollution, and genetic predisposition. So again, from an academic point of view, what are the various familial syndromes that are associated with head and neck squamous cell carcinoma? These syndromes run in the families and they have an increased risk of having head and neck squamous cell carcinoma. The most common is being Fanconi's anemia, Bloom syndrome, xeroderma pigmentosum, ataxia, telangiectasia, and Lee-Fromeny syndrome. So what is the odds ratio, or what is the risk involved for a smoker and an alcoholic? So this is a beautiful paper by Mia Hashibe, a must read for everyone who's dealing with cancer. It says about alcohol drinking in never users of tobacco and cigarette smoking in never drinkers. The odds ratio for smokers who don't drink, in males it is 2.13 times, females 2.33 times. There's a dose response relationship depending upon the frequency, duration, and the pack years. Pack years is defined as the number of cigarettes, number of packets of cigarettes that is consumed in a year, in a day, and provided one packet is taken as 20 cigarettes. The pipe and cigar, the odds ratio is 3.5 to 3.7x. Coming to alcohol, more than 3 drinks per day, the odds ratio is 2.04. Smokers and alcoholics, it's much more. We all know there's a synergistic effect of alcohol when it is added to smoking, the odds ratio being 5 to 7 times more. Secondhand smoking, it's very interesting to note that secondhand smoking has a higher incidence. They are at higher risk for cancer than firsthand smoking, the odds ratio being 2.4 to 5.34. So as I was talking about the synergistic effect of tobacco and alcohol, what is the mechanism of action? The addition of alcohol, how does it add? How does the synergism act? So there are 10 points that leads to the synergism between alcohol and tobacco. First of all, alcohol acts as a solvent for the tobacco carcinogens. It increases the mucosal permeability to the carcinogens, especially to the keratinized mucosa of the oral cavity. There is increased cytochrome P450 activity, which leads to the conversion of the protocarcinogens to carcinogens. They impair the immune system, the macrophage activity, the T lymphocyte function. They reduce the activity of the DNA repair enzyme, increasing chromosomal damage and instability of the genome. Reactive oxidant species, which are superoxide ions, damaging to the mucosa, depletes the body of the antioxidants, P53 mutation, which is the guardian of the genome. And then we have hormone alteration, not much of a role in oral cavity, but yes, there are higher levels of estrogen, which leads to CA breast in females. So something about field carcinogenesis is a very important and a very basic concept, which was brought about by Danley P. Slaughter et al. In the year 1953. So what he said was, because of this carcinogen, there is carcinogen-induced condemned mucosa in the whole upper aerodigestive tract of a head and neck cancer patient. When you talk about the upper aerodigestive tract, it starts from the oral cavity or the nasopharynx up to the GE junction. It's a multi-step process which is accumulated genetic alterations at multiple levels. It is multi-centric in origin. It's not just the cancer that you're seeing. Maybe you have more than one cancer. This is the reason. Field carcinogenesis is the reason for multiple or second primary tumors. Again, a very beautiful paper, a must read for anyone who's dealing in oncology. It was J. Califano in the year 1996, which spoke about the genetic progression model. He spoke how does a normal mucosa convert or change or transforms into invasive or frank carcinoma. The first being, you can see the progression model on the screen, the normal mucosa because of the carcinogens. Then we have the hyperplastic, hyperkeratotic squamous mucosa. And then we have multiple grades of dysplasia ranging from mild, moderate, and severe. Then we have carcinoma in situ, where the cancer is sitting over the basement membrane. It has not invaded the basement membrane. And once it invades the basement membrane, we have something called an invasive carcinoma or a frank carcinoma. Always remember, clinically, normal mucosa can be molecularly abnormal. There can be no presentation without this hallmark of cancer. There's a famous model by Hanahan and Vanberg. So these are the 10 mechanisms through which cancer develops or carcinogenesis happen: evading growth, suppressors, avoiding immune destruction, enabling replicative immortality, tumor promoting inflammation, activating invasion and metastasis, inducing angiogenesis for its growth, genomic instability and mutation, resisting cell death, deregulating cellular energetics, sustaining proliferative signaling. Before I talk about cancer, there's something that we need to know, and we all deal, especially in our oral surgery department, with OPMDs. So it is oral potentially malignant disorders. Before 2005, it was commonly during my UG days, it was called pre-malignant lesions, pre-malignant conditions. But in the year 2005, WHO changed the nomenclature and they were all clubbed together. And now they have a standard term that is oral potentially malignant disorder. And the standard definition is any oral mucosal abnormality that is associated with a statistically increased risk of developing oral cancer. So there's this beautiful paper by Saman Varnakula Surya. He's one guy who has worked a lot in OPMDs. And these are the various OPMDs that has been listed and has been classified according to the latest classification in 2020. So, and the risk of malignant transformation. Why it is important? We need to know, if we are dealing with the leukoplakia, what is the risk of malignant transformation? So the most common is being leukoplakia, 2 to 8%. When you talk about leukoplakia, you have homogeneous and non-homogeneous. Proliferative verrucous leukoplakia, it's altogether a different entity. It has nothing, it's totally different in its behavior when compared to the leukoplakia. And the malignant transformation rate is almost more than 90%. Erythroplakia, fiery red patches, 40 to 50% risk of malignant transformation. Oral submucous fibrosis, 7 to 8%. Oral lichen planus, less than 1%. Actinic keratosis, palatal lesions in reverse smokers, oral lupus erythematosus, dyskeratosis congenita, and the newly added ones are oral lichenoid lesion, oral graft versus host disease. This is something we all encounter in our OPDs on a daily basis, leukoplakia, and it's still a clinical dilemma. We are still stuck as to how to go about it. We still don't have an answer to it. So there's a beautiful paper by Isaac van der Waal. He defined the red flag signs, which leukoplakia should be intervened, or which one looks more dangerous than the other, and how to go about it. So what are the red flag signs when you see a leukoplakia? When you should do a biopsy and when not to do a biopsy, when to wait and watch, when to intervene. So the first commonest form being a non-homogeneous leukoplakia. When you talk about non-homogeneous, we have nodular verrucous speckled leukoplakia, of which speckled leukoplakia is the most dangerous. It is also called leukoerythroplakia. If it's in a female gender, then it is a high risk. Long duration of leukoplakia for almost 1 to 2 years, then you should do a biopsy to make sure what's the degree of dysplasia. Leukoplakia in non-smokers, location being tongue and floor of the mouth are at high risk of malignant transformation. Size of the leukoplakia more than 2 centimeters square. Presence of added fungal infection, that is Candida albicans. Presence of epithelial dysplasia. So what is the clinical presentation of a patient when he comes to an OPD? What does he complain of? So these are the various chief complaints that you would encounter in a not just oral cavity. This for all head and neck cancer patients. They would come up with a nasal mass obstructing the nasal cavity, epistaxis, that is bleed from the nose, alteration in smell, cacosmia, anosmia, non-healing ulcer, long-standing, reduced mouth opening, trismus, which is a very important finding and clinically tells us that you're dealing with the advanced stage because now the disease has gone into the masticatory space. Mobile dentition in an otherwise healthy jaw young patient. You have mobile tooth. You should think of squamous cell carcinoma. Odynophagia, difficulty in swallowing, hot potato voice, a clinical symptom seen in oropharynx, dyspnea, difficulty in breathing, hoarseness or change or alteration in voice, a common feature of CA larynx. Dysphagia, difficulty in swallowing, and maybe at times there are no symptoms. They will just present with an unexplained neck swelling. So what does a workup look like? How to go about this patient? Many a times I get calls from Anita asking like, what should we do now? Should we do a biopsy? Should we do a imaging? So there are standard guidelines which govern the onco world. So I'll just brief you about the workup, what we do in a cancer patient. The most important and the first sitting, what you're supposed to do is a biopsy. When you talk about biopsy, there is no alternative to a biopsy. And it should be an incisional or a wedge biopsy with good depth, or it could be a deep punch biopsy with your punch forceps. It should be from the most representative site of the lesion. Ideal is the indurated margin of the ulcer. Avoid central portion of the ulcer, which would be focal areas of necrosis, and you might not get a definitive diagnosis. And please avoid excisional biopsies. It is not warranted. It is not safe to do excisional biopsies if you're thinking in terms of cancer. And have a good rapport with your pathologist. Know your pathologist, know what he wants, and unless and until we give them a good sample, you cannot expect a good report. Coming over to imaging, we have a lot of imaging modalities these days, ranging from IOPA, OPG, CBCT, CT scan, MR, PET scan, SPECT, bone scintigraphy. So what is the ideal imaging? So when you talk about, this will be just for oral cavity. When you talk about imaging, so there is imaging of the primary, then we have imaging of the neck, and then we have imaging for distant metastasis. So this is a beautiful paper by Suprita Arya ma'am from TMH Mumbai, which talks about the imaging in oral cancer. It's like she is teaching you through this paper, very simple and very elaborate, and a beautiful paper to know how to read a CT or an MRI. When you talk about gingivobuccal and the RMT tumors, that is buccal mucosa, RMT, lower GBS, upper alveolus, lower alveolus, hard palate, the ideal modality to image the primary is CECT neck, contrast enhanced computed tomography of the neck. And please, whenever you order, please write. In most of the standard institutions, they would go for a puffed cheek view, but please write that you need a puffed cheek view wherein the patient fills air inside his mouth. Why is it important? I'll tell you. So these are the two images that we can see, and the first one is a non-puffed view, and the second one is a puffed view. We can see here there's a heterogeneously enhancing lesion with respect to the left buccal mucosa, and in a non-puffed cheek view, we see that the tumor is abutting the mandible. So you might think of doing a marginal or a segmental, and you might think the tumor is very close to the mandible. But whereas in the puffed cheek view, it's altogether a different picture. You have a heterogeneously enhancing mass, and there is a good space. It is well away from the lower alveolus, and mandible is totally unharmed or uninvolved. From academic point of view, there's something very interesting for those who wants to do their fellowship in head and neck onco. Buccomesenteric triangle, an important landmark, which is bounded anteriorly by the zygomaticus major, posteriorly by the masseter, and medially by the buccinator. When you talk about buccal mucosa, if the disease is involving the mucosa, then buccinator becomes your margin. If the buccinator is involved, then the skin becomes your margin. That is a thumb rule that we use. This is again a CCT of the buccal mucosa cancer, wherein we have the cancer that is spread onto the masticatory space. We can see the ramus of the mandible here. On the lateral aspect, we see the masseter. On the medial aspect, we have the medial pterygoid, and we can see a heterogeneously enhancing lesion on this coronal section, which is infiltrating the masticatory space. And not just that, it has invaded into the skull base. You can see widening of the foramen ovale. On the bony section out here on the right side, there's widening of the foramen ovale. These are all inoperable tumor. So what does a surgeon want when he sends a CCT neck or a CCT face to a radiologist in his reporting? So we need to know the epicenter of the tumor. Where has the tumor started from? We need to know the dimension of the tumor, where all the tumor has gone. We need to know the soft tissue extent, lateral, superior, medial, overlying skin, maxillary sinus, paramandibular extent, lingual muscles, base of tongue, floor of mouth, because it's all important to stage the disease, which I'll be talking about later on. We need to know about the bone erosion, which is a major decision that the surgeon has to make intra-op. How is he going to manage the maxilla and the mandible? And the extent of erosion, whether it's just a subtle cortical erosion, or you have infiltration into the marrow. Coming over to the neck, we need to know the nodal status, that is the number and size of the abdominal nodes, level of the nodes, presence of central necrosis, EME, extracapsular spread, and invasion of the adjacent structure and the vessels. Now, coming over to tongue and floor of mouth, please mind it, these are all soft tissue structures. The ideal imaging for tongue and floor of mouth is not CECT neck, it is MRI. So this is a MR of the head and neck region where we have a hyperintense signal intensity with respect to the right lateral border tongue, and we can see it is involving the neurovascular bundle. And there's a coronal section where we see again a hyperintense signal intensity with respect to the left lateral border of the tongue, and we can see the disease is approaching the midline or almost reaching midline. These are very important radiological features which will be helping you in taking your decision while you plan your resections. This is a sagittal view wherein we again see this again a MR neck where we see a hyperintense signal intensity with respect to the tongue, and now the disease has gone into the floor of the mouth, the mylohyoid is involved, and it is abutting the mandible. And here we see the lesion has involved, the disease is involving the mandible, there is hyperintense marrow intensity, and mandible is frankly involved. So when you talk about an MR, what is the ideal reporting? How does a reporting look like? What is the checklist that we need to follow, or the radiologist while reporting needs to follow? Again, we need to know the epicenter, the tumor thickness, the involvement of the extrinsic muscles of the tongue, intrinsic muscles, and the floor of the mouth. That is something very important. Whether the tumor is approaching the midline, crossing midline, is it involving the ipsilateral or the contralateral vascular bundle, posterior extend to the ipsilateral base of tongue, contralateral base of tongue, extended to the oropharynx, preepiglottic space, hyoid bone, posterior extend to the masticatory space, pterygoid plates, mandibular involvement, and the nodal status. Now, we discussed about the imaging of the primary. Now, how to image the neck? Do we go for a different imaging for the neck, or we go for the same imaging that we used for the primary? So, for tumor that are very thin, very superficial, with a clinical depth of almost less than 3, wherein you're not planning, your digital palpation is telling it's very superficial to the mucosa and there is no deep infiltration, and you can do without imaging the primary. In such a case, USG neck becomes a very cheap and a non-invasive modality to image the neck. Whereas the thumb rule is the same modality that you're using for the primary, for the oral cavity, the same modality should be used for the neck as well. So for gingivobuccal RMT tumors, if you're going for a CCT neck, the same can image the a CCT neck. For oral cavity, the same can image the neck. And for tongue, floor of mouth, if you plan to go for an MR, the MR can say the same modality can image the neck as well. This was the paper that brought a clarity about the detection of cervical lymph node metastasis in head and neck cancer patients with a clinically N0 neck. It was a meta-analysis comparing different imaging modalities. They used, the modalities were ultrasound, CT, MR, and PET scan. Now, coming over to distant metastasis, because if a patient is having distant metastasis, then he loses the curative intent of treatment. He straight away becomes palliative. So when you talk about early stage, that is T1N0, T2N0, there is no need for doing a distant metastatic workup. It is not required. The most commonest sequence of distant metastasis in head and neck cancer, it's first the thorax or the chest, then the liver, the bone. What the ideal imaging modality as of now in low resource setting, it is non-contrast or a plain CT of the thorax or an HRCT. Extrathoracic metastasis, that is metastasis outside the thorax without a mets in the thorax, is less than 1%. So you image the thorax, that is more than enough in that to in advanced cases. There's a review paper, there's a meta-analysis by Zhu which talk about PET scan. We all know it's a hype that is created in the cancer world. It's of much of a use with very high specificity, sensitivity for detecting distant metastasis, synchronous primary, second primary tumors, cancer surveillance, recurrent setting. It's all PET that is used these days. If you have that facility, might as well go for PET, or else a CT scan of the thorax is more than enough for distant metastasis. This is again a very important paper wherein they have compared the specificity and sensitivity of chest X-ray compared to CT chest and PET-CT for detection of distant metastasis, synchronous primary in oral, pharyngeal, and laryngeal cancer. And they saw that PET had good sensitivity than CT chest and than chest X-ray. Now, once you have seen the patient, you have done your imaging. So the patient will ask, so what is my stage? So it is important as a clinician or an oncologist for you to stage the disease now. And always remember, the staging is always clinico-radiological. It's not just clinical or radiological, it is clinico-radiological staging. So the norm, the guideline that we follow today is AJCC 8th edition, and it's available online for free. Those who are interested can download or let me know, I can send you a copy. The clinical staging is named as CTNM, and we have two staging. One is clinical staging, that is the clinico-radiological staging. And then after the resection, we have the pathological staging, that is the PTNM staging. So why is staging important? Why we have to stage the disease? So first is to know about the prognosis, how bad the disease is, to decide on the survival, to educate the patient. Then it helps us to the management of the disease. How are we going to manage it? Will it be a curative intent? Will it be a palliative? Or will it be a best supportive care? For communication with other surgeons or radiation oncologists or medical oncologists, for documentation and for research purposes. So when you talk about TNM staging, AJCC 8th edition, as I said before, is what we follow. And all these years, tumor thickness was the term that was used. But there is something newly added in the AJCC 8th edition, which is important for all postgraduates and those who want to do fellowship in head and neck onco to remember the new entity that we have added is depth of invasion. So they saw that depth of invasion was more informative and much more of a prognostic factor than the tumor thickness. How? I'll just cite an example. So here we have a proliferative tumor, and we can see the white line, the vertical white line, that is the tumor thickness. And we might think that the tumor is so big because it's a proliferative component that is added to the tumor. But at the same time, if you want to calculate, if you want to look into the depth of invasion, we have two lines that we need to draw. One is the horizontal line, which is called the horizon, that starts from the adjacent normal basement membrane. And you have a vertical drop down, this is blue line, that's called the plumb line. And we can see this blue line is much more longer or deeper than this white line below the basement membrane. I'm not concerned about what's outside. My concern is how infiltrative my tumor is. So in a proliferative tumor, always remember, most of the times, tumor thickness will be more than the DOI. And whereas in an ulcero-infiltrative or an ulcero-indurated lesion, we can see now there's no proliferative component. We might think that this is a small tumor, but when you draw your horizon from the adjacent basement membrane and a vertical drop down, that is a plumb line, to the deepest infiltrative point of the tumor, we can see that this is much more of a dangerous tumor when compared to a proliferative one. So that is the reason that they added depth of invasion into the AJCC 8th edition. This was the landmark paper that brought in depth of invasion into AJCC 8th edition, and happy to have Dr. Pankaj Chaturvedi as a contributor from India TMH Mumbai. So they saw that with the increasing depth of invasion, they divided depth of invasion into less than 5 to 10 mm, and more than 10 mm or 1 centimeter. And they saw that with increasing depth of invasion, there was deterioration in the prognosis with respect to the disease-specific mortality and the loco-regional failure and the overall survival. So this is something very basic, very important for us. So what is the T category? The T stage that we call. So TX is primary tumor cannot be assessed. TIS is carcinoma in situ, where you have the tumor over the basement membrane. T1 is any tumor that is less than 2 centimeter with depth of invasion less than 5 mm. T2 is less than 2 with DOI more than 5, or tumor 2 to 4 with DOI less than 10 mm. T3 is between 2 to 4 with DOI more than 10 mm, or tumor more than 4 centimeter and DOI less than 10 mm. T4, we have two sections, T4A and T4B. T4A is moderately advanced disease. Any tumor that is more than 4 centimeter and DOI less than more than 1 centimeter, that is T4A. If the tumor is invading the bone, that is T4A. If the tumor is invading or infiltrating the skin of the face, again, that is T4A. Mind it, superficial erosion of the bone or the tooth socket alone by a gingival primary is not sufficient to classify a tumor as T4A. T4B, it's before it was in AJCC 6th edition, it was unresectable, inoperable tumors. But now in AJCC 8th edition, with the advancement in the surgery and the surgical techniques, it is now no more inoperable or unresectable. It is very advanced local disease. It is tumor involving the masticatory space, the pterygoid plates, the skull base, or in cases the internal carotid artery. Mind it, DOI is depth of invasion and not the tumor thickness. The second change that was brought into AJCC 8th edition when compared to the nodal staging was the introduction of extranodal extension. How do you define it? Extension of the metastatic tumor beyond the fibrous capsule of the lymph node into the surrounding connective tissue. But that's the pathological definition. Clinically, as a clinician, how can you classify a node as ENE or having extracapsular or extranodal extension? The various clinical signs that you need to elicit is they should be hard and fixed nodes, conglomerated or a group of nodes which are attached to each other, invasion of the overlying skin, dysfunction of the cranial nerve, brachial plexus, sympathetic trunk, or phrenic nerve. Coming out to the N category, AJCC 8th edition, we all know it's just ENE that has been added and everything else remains the same. N0B, no regional lymph node mets. N1, metastasis in single ipsilateral lymph node, 3 centimeter or smaller in greatest dimension with no ENE. N2A is metastasis in single ipsilateral node larger than 3, not larger than 6 centimeter in greatest dimension, negative for ENE. 2B is multiple ipsilateral, none larger than 6 centimeter in greatest dimension, and ENE is negative. 2C is bilateral or contralateral nodes, and none of the nodes are larger than 6 centimeter, and it has to be ENE negative. N3, again, before we had just N3, now we have N3A and N3B in the AJCC 8th edition. N3A is metastasis in the lymph node that is greater than any big node that is greater than 6 centimeter with no ENE is N3A, and any node irrespective of the size, if you can elicit extranodal extension, it is N3B. Then remember that you're dealing with the N3B node. Coming over to the metastatic staging, clinical M stage, it remains unchanged. CM0 is no distant metastasis and CM1 is distant metastasis. Now based upon the T, N, and M, we have the final staging. So T1, N0, M0 is stage 1. T2, N0, M0 is stage 2. And the moment we have T3, it becomes stage 3. N1 disease, again stage 3. The moment we are dealing with a T4A tumor, remember T4A is more than 4 centimeter, DOI more than 1 centimeter, infiltrating skin, frank bone erosion, it becomes T4A, that is stage 4A. N2 disease is again stage 4A. N3 disease is 4B, irrespective of the T stage, and T4B disease, irrespective of the N stage, it's again 4B stage. And M1, it is 4C. Now, the question is the overall survival of the patient. The thumb rule that we follow, there's a lot to it. It's again a very big topic. I've just written the thumb rules. The presence of a metastatic node in the neck in the oral cavity cancer takes up the patient to stage 3 and reduces survival by 50%. The presence of extracapsular extension or extranodal extension, that is, you're dealing with an M3B node, further reduces by 50%. That is, it becomes 25% now. In early stage oral cavity, that is stage 1, stage 2, T1, N0, T2, N0, the survival is almost more than 70%. Lip and all, you have a survival more than 90%, 5-year overall survival. In advanced stages, stage 3 and stage 4, as I said, it decreases by 50%. It comes over to just 30 to 40%. Now, how do we manage it? So the thumb rule that we follow in oral cavity for all early stage tumor, stage 1 and stage 2, T1N0, T2N0, it is just single modality treatment. And the guideline says it is surgery and not RT or chemotherapy. But when it comes to advanced stage, stage 3, stage 4A, stage 4B, it's altogether a multimodality treatment when it comes to a curative intent with primary surgery And after surgery, within 4 to 6 weeks, we need to give adjuvant RT or CTRT, chemoradiation, based upon the final HPR. But these days we have brachytherapy that has come into, and if it's accessible lesion, small lesion, T1 lesion, due to aesthetic reason, we can still go for brachytherapy, provided you are dealing with an N0 neck. How to manage mandible, something that is very favorite to OMFS guys. When to do a marginal, when to do a segmental mandibulectomy. We have clear guidelines, clear indication. There's no confusion. So these are the indications for doing a marginal mandibulectomy. So tumor, if it is just abutting the bone, to take as a margin, you just do a marginal mandibulectomy, and mind it, it should be below the level of the tumor. So always slant your a bony cut or the osteotomy cut so that you just don't cut into the tumor. Subtle superficial cortical erosion. And in many a times, you might do a reverse marginal mandibulectomy. For postgraduates, they might ask you in your exam, what is reverse marginal mandibulectomy? If you have a 1B node that is fixed to the inferior border of the mandible, you might have to take a rim of the mandible, inferior border of the mandible. When you have frank cortical erosion, marrow invasion, paramandibular spread, that is disease in the soft tissue going along the whole length of the mandible, you have to do a segmental mandibulectomy. Edentulous mandible, we all know that it undergoes alveolar resorption. We are dealing with a pipe stem mandible, radiated mandible. Because of the incidence of osteoradionecrosis, it is always better to go for a segmental mandibulectomy. The thumb rule that we follow is height of the remnant native mandible, the mandible that will be in the oral cavity post resection, should be more than or equal to 1 centimeter. Otherwise, there are high chances of having pathological fracture in the later stage. This is again a very important paper, a must read, by Kuao. He explains about the different imaging techniques in the diagnosis of head and neck cancer for mandibular invasion. He has used all the modalities in the study, that is CBCT, SPECT, CT MRI, OPG, PET CT, bone scintigraphy, and he has seen that CT and MRI, which we use most common for our oral cavity cancer, are more suitable for confirmation of the invasion of the mandible. Now, coming over to T4B tumors, mind it, in AJCC 6th edition, this was unresectable, inoperable cancer. But now with the advancement of the surgery, the newer techniques, these days we have something called a compartment resection. T4B is no more unresectable or inoperable. There's a landmark paper, a must read, in the Journal of Oral Oncology in the year 2007. There's a paper from Taiwan by Liao and group, which says T4B oral cavity cancer below the mandibular notch is resectable with a favorable outcome. So what they did in the paper was, so they drew a line at the sigmoid notch and they divided the tumor into infranotch tumor and supranotch tumor. And they said that infranotch tumor behave as though involvement of the masticatory space is there. It is a T4B tumor, but they have much more better survival in terms of locoregional control or overall survival. And they, in most of the N0 cases, it just behaves as a T4A tumor. But supranotch, yes, there are high ITF tumor, and there is something more that you need to add when dealing with supranotch tumors. So always remember, the thumb rule is just check for the sigmoid notch, whether the disease is below the sigmoid notch or it is crossing the sigmoid notch. If it is below the sigmoid notch, you can go ahead with upfront primary curative intent surgery and you can get away with clear margins on your final HPR. Now, is there a role of neoadjuvant chemotherapy in oral cavity? Do we have to give, or which are these clinical scenarios where we give chemotherapy before operating a oral cavity cancer? Again, we have clear guidelines, and this was brought into light again by TMH, Dr. Patil's paper. And these are the 5 guidelines. This was a retrospective study, but because of the case numbers, it was taken as a guideline. And these are the 5 indications. Other than this, there is no indication to give preoperative or neoadjuvant chemotherapy for oral cavity cancer. The first being buccal mucosa primary with diffuse margins and peritumoral edema going up to or above the level of the zygomatic arch. You have a big buccal mucosa infiltrating the skin, going above the zygoma. You should think of giving chemo first. What is the benefit we get with chemo is we downsize the tumor. It becomes easy for the surgeon to resect the tumor once the tumor has downsized. Second indication being tongue primary anterior two-third, that is the oral tongue, with the tumor extending into the base of tongue, reaching up to the level of the hyoid bone. Extension of the tumor into the vallicula is an indication for neoadjuvant chemotherapy. And then, as we discussed before, extension of the tumor into the high ITF. How do we define high ITF? It's the disease that goes above the sigmoid notch. Then extensive skin infiltration impacting the achievement of negative margin. So these are the 5 indications where you can request your medical oncologist to give a neoadjuvant chemotherapy, a 3-drug regimen for oral cavity cancer, and maybe post 2 to 3 cycles, you assess it and whether the tumor is downsized, and then you can go ahead with surgery, and it should be done within 3 weeks. So how do you manage neck? So we just spoke about how we manage the oral cavity cancer. How do we manage neck? When we have to do neck dissection, neck dissection is an integral part when you're dealing with oral cavity cancer. So just some basics. These are the various levels of the neck. We all know we have 1A, which is bounded by the antebelly of digastric and the chin up and the hyoid bone below. 1B, that is formed by the body of the mandible superiorly, anterior belly of digastric, posterior belly of digastric, and the floor being the mylohyoid. And then we have the upper jugular from the skull base to the hyoid. And then we have from the hyoid to the lower border of cricoid, level 3, and from lower border of the cricoid up to the clavicle, level 4. Then we have the posterior compartment, 5A and 5B, which is a point of convergence of the sternocleidomastoid and the trapezius muscle. And 5A and 5B is divided by the cricoid cartilage. Above the cricoid cartilage, we have 5A, and below the lower border of cricoid cartilage, we have 5B. Then we have the central compartment, that is from the hyoid to the suprasternal notch. This is the echelon for thyroid cancer, which is bounded laterally by the bilateral carotids. And then we have the superior mediastinum, that is from the suprasternal notch to the innominate artery. So what is the echelon nodal basin? As an oncologist, when we are dealing with oral cavity cancer or a head and neck cancer, we need to know which sites drain to which region. So this was a landmark paper that was brought about by Dr. Jatin Shah. And we all know the echelon primary nodal basin for oral cavity is 1A and 1B. 1A is for lip, anterior mandible, and anterior floor of mouth, anterior tongue. Then we have 1B. Then level 2 is for nasopharynx, parotid, oropharynx, and level 3 you can have oropharynx, larynx, hypopharynx, thyroid. Levels 5 we have nasopharynx, thyroid. Level 4 we have thyroid, larynx, hypopharynx, cervical, esophagus. Why is it important is many a times you will have a patient in your OPD which just comes with a neck swelling, and depending upon at what level is the neck node, you can start thinking where will you find the primary. That is why this is important. We call them carcinoma of unknown primary or cup patients. So this is an exam question. I always remember as a postgraduate, they used to ask, how do you manage a M0 neck? For all the postgraduates, there's a landmark paper, again, to be proud of. It's from our country by TMH, Dr. Anil D. Cruz and group. This was NEGM in the year 2015, which laid the foundation or the guideline for M0 neck. Should you wait and watch or should you do a selective neck dissection? So it's good number of patients, around 500 plus, which were divided into 2 arms. One underwent elective neck dissection and the other was a wait and watch policy, and a therapeutic neck dissection was done. And they saw that there was a survival benefit with elective neck dissection. This benefit was 12% in overall survival and 24% benefit in disease-free survival. So the current guideline that we follow is any oral cavity cancer with an M0 neck, you're supposed to address the neck. Now, when to address the contralateral neck or the other side of the neck, when to do a neck dissection on the other side. Again, a paper by Kowalski, which laid the foundation and the guideline for contralateral neck dissection. The indicators being tumor approaching or crossing the midline, mostly midline tumors, tongue, floor of mouth, approaching or crossing the midline. Heavy nodal burden on the ipsilateral side, you have N2B nodes, you should go for a contralateral neck dissection. Midline nodes, you should address both sides of the neck. So the thumb rule as a clinician that we need to follow is, for an N0 neck, you need to address neck dissection has to be done. There are no doubts about it. And the levels that needs to be addressed for oral cavities, level 1 to 3. But for tongue and floor of mouth, there's a Brown's paper speaking on skip metastasis. Again, a very important concept, especially for tongue, floor of mouth. You are supposed to address level 4 as well, though the paper has its own fallacies. When it comes to N plus neck, when you're dealing with a neck positive neck node, it's not just a selective neck dissection. You have to go a bit more. You have to clear from level 1 to level 5 for an oral cavity cancer. Contralateral neck, as I stated before, tumor approaching or crossing midline, heavy nodal burden on ipsilateral side, and midline nodes, you need to address the other side of the neck as well. Now, I'll show you the clinical cases that I've done here. So this is a squamous cell carcinoma of the right lateral border tongue. So glossectomy was done. The glossectomy has a very good classification, standard terms. So this is the most easiest one of the first type 1, that is partial glossectomy. So we can see there was a tumor on the right lateral border tongue, and then we have resected the tumor with good clinical margins. As a surgeon, intra-op, you should achieve at having a margin of 1 to 1.5 centimeter for you to expect a clear margin in the post-op HPR or the pathological HPR. And so that's the defect post-resection, and the tongue was primarily closed. The school of thought is, if the tongue volume loss is less than 30%, you might not go for a flap, but you can just close the tongue primarily, or the famous samosa technique, we call it. And then there is another case. This is again carcinoma. Sorry, the image is overturned. It is carcinoma left lateral border of the tongue, wherein a hemiglossectomy was done. Half of the oral tongue was taken out, and that's the sublingual gland that you see over there that was taken as a deep margin. And that is the post-resection defect. You can see half of the tongue, oral tongue, is gone. In such a case, primary closure is not a feasible option. Patient will have difficulty in speech, swallowing. So what we did, we took a mucosal flap. This is called a FAM flap. It is facial artery myomucosal flap, beautiful flap inside the oral cavity, mimics the tongue exactly, and no extraoral scars or a second site morbidity. You will just get it inside, and with a BFP you can close the defect and you can just rotate it. It is based, provided you have preserved your facial artery in the neck, it is based upon the facial artery, and that's the inset of the flap and sutured primarily to the remnant tongue in the oral cavity. So this is a composite resection. Sometimes it's not just the tongue. Here we have a squamous cell carcinoma, left lateral border tongue, where we can see the tumor is not just on the lateral aspect, whereas it is going on to the ventral aspect of the tongue and then onto the floor of mouth. And it is very close to the mandible. So mandible was taken as a margin. In such a case, as I said before, there is no need to do a segmental mandibulectomy. Just do a marginal, take a rim of a mandible and make sure you leave more than 1 centimeter margin inside the oral cavity. And this is the defect post resection. And what I did in this case was an infrahyoid flap. It's a beautiful flap that we get from the neck, and exactly you can mark the other side of the tongue on the neck, and it is based upon the superior thyroid artery and vein, and you can tunnel it inside into the oral cavity, and it has been closed primarily into the neck. And neck closure becomes a task here, so make sure that you get a closure something like this. Otherwise the neck wound closure might just gape in the post-operative phase. This is near total glossectomy. Near total glossectomy means the whole of the oral tongue was resected along with the ipsilateral base of the tongue. This was a young girl, 29-year-old female from Kohima. She had squamous cell carcinoma, left lateral border tongue, ulceroindurative lesion, crossing midline, going into the ipsilateral base, and the contralateral base of the tongue was free. So what we did was, we did a near total glossectomy, that is the oral tongue. And what we see, the hypertrophied thing here is the ipsilateral base of tongue, and the contralateral base of the tongue was preserved in the oral cavity, and a rim of the whole mandible was taken as margins. This was the post-resection defect, and we took a pec major flap for her, and this is the neo tongue that we reconstructed for her. Now coming over to buccal mucosa. So this is a case of squamous cell carcinoma buccal mucosa where I did a composite resection, wide local excision of the buccal mucosa with marginal mandibulectomy and the upper alveolectomy. So a rim of the, because it was very close to the upper and the lower GBS, so a rim of the upper alveolus and the lower alveolus both were taken as a margin, and the skin and the tumor was very close to the extraoral skin. So cuff of the extraoral skin was also taken. So that's the post-resection defect. You can see a rim of the mandible was taken, bone wax lying there. It was inferior partial maxillectomy. You can see the maxillary sinus that is open, and that is we took a pec major flap and we did a bipadal PMC, wherein you can see how nicely it has set inside the oral cavity, the new buccal mucosa, and the extraoral defect was the PMC was bipadal, and it was reconstructed with the PMC on the skin. Many a times we come across, not just we know, okay, this is a cancer, we know how to deal with it, but many a times we have a surrounding leukoplakia along with it. So it is a squamous cell carcinoma with an adjoining leukoplakia. Such lesions are much more tricky to excise. And this was a lady with squamous cell carcinoma, right buccal mucosa with a leukoplakic patch extending into the RMT region, extending into the tonsillolingual sulcus, and it was very much close to the skin. So this was the margin that was taken on the skin. And that is the post-resected resected specimen. You can see that's the oral commissure. You can see the tumor has been excised with good clinical margins. And you can see the leukoplakia was also added, and we took a margin to the leukoplakia, and the rim of mandible was also removed. This is the extraoral pic of the resected specimen, the angle of the mouth, the oral commissure, and the extraoral skin that was excised. So that was a defect. Neck dissection was done. SCM was sacrificed for the inset of PMC into the neck. This is the great vessel IJV, spinal accessory was preserved. And then we did a bipadal PMC for her. You can see the inset of PMC intraorally and extraorally, and that's the PIC post-recon. Now coming over to RMT tumors, again, a very tricky site. This is a site that I fear the most. So this was a case of squamous cell carcinoma, right RMT, where I did a composite resection, wide local excision of the right RMT, marginal mandibulectomy, and inferior partial maxillectomy. That's the resected specimen where we see the mandible, the maxilla that was resected, and the tumor is sitting here. It's not so clear, and that's the lateral aspect of the mandible with the cuff of masseter that was taken, as it was a T4B tumor. Minded, as I said before, it was an infranotch disease, so it was upfront operable, and we took a good cuff of the muscle as margin. That's a post-resected PIC, and a PMC was taken from the chest. And this was the new buccal mucosa that we created with PMC, competency of the oral commissure, and this was the closure of the face, the oral cavity, the neck, and the chest. So this is another case of RMT where we did not do a marginal mandibulectomy, wherein I did a segmental mandibulectomy because it was high ITF disease. I had to clear it's not so clear. You can see the skull base here. So I'd gone up to the skull base because that is the margin for high ITF, and the disease, the tumor was taken out fully, and that's the resected specimen. And that's again, a pec major was taken, and it was inset into the defect and was closed. Again, a floor of the mouth where we have a tumor that's sitting here, squamous cell carcinoma on the floor of the mouth. So this was going into the RMT. This was involving a lot of subsites of the oral cavity. You can see mandible was taken, tongue was taken, a part of the oropharynx, tonsil was taken. That's the masseter muscle that was taken along with the tumor. So again, a PMMC was taken, and that's the new buccal mucosa that was reconstructed, and this is the post-op PIC. Coming over to lip, this is a squamous cell carcinoma, lower lip for a 73-year-old male patient, and the whole lower lip was involved, and involving the bilateral oral commissure, right and left side. That's the resection. That's a mucosal margin that was taken. That's the extraoral portion of the lip that we see, and a neck dissection was done. And then what I did in this case was, when it comes to lip closure, it's again very dicey. He was a very old patient. I could not we couldn't plan big flaps here. So I went for a bilateral nasolabial flap, which Max Fac surgeon does on a regular basis for OSMF. So bilateral nasolabial flap was taken, and both were inset into the defect. Immediate post-op pick, he looks like a Hanuman here, but after a few days, once the edema and everything has subsided, it has come out beautifully. You can always try Karapanzic flap. If the volume is less than 30%, you can close the lip also, or you can go for Aby's or Aby Eslander flap. So as I said before, in AJCC 6th edition, such tumors you will not touch. It was called inoperable or unresectable. But with the advancement in surgery, these tumors are no more unresectable. Before, all these patients would just go into palliative intent of treatment. There will be no curative intent that was given to them, and these patients would die in a year's time. So now we are able to remove the tumor from the skull base. This was a high ITF buccal mucosa, and you can see the endotracheal tube that is seen. We had taken the hard palate, the upper alveolus, inferior partial maxillectomy was done, and that's the inferior turbinate of the nasal cavity, and there's a skull base with foramen ovale on it, and then we had done a segmental mandibulectomy so that we get good access into the skull base. So again, a pec major flap was taken, and that is the post-op recon and post-op pick post-closure. Coming over to hard palate, this was a small tumor on the hard palate for a 75-year-old lady, which was biopsied. It was squamous cell carcinoma, and that's the clinical margin that we got intra-op. And what I did in this case was I took a split thickness skin. I took a split thickness skin graft, and that was inset into the defect, and a bolster was applied. And this is how the skin graft looks after 2 weeks. Coming over to CA maxilla. So this was a case of CA right maxilla where the tumor was involving the maxillary sinus. Always remember, this maxilla patients, they will always come in very late stages, very late presentation. By the time tumor would have involved a lot of spaces. So a total maxillectomy was planned, wherein we can see the anterolateral wall of the maxillary sinus, the medial wall. That's the upper alveolus along with the hard palate on the down surface, and that's the floor of the orbit. So what I did was I gave for, when it comes to such a big resection, you have to take care of the orbit. The orbit just should not fall down. So a titanium mesh was given to support the orbit, and a temporalis muscle flap was taken from the adjacent forehead, temporal surface of the skull, and that was inset into the defect and closed primarily. And the incision that we used was a modified Weber-Ferguson. So that's squamous cell carcinoma of the right side of the face, wherein we took the tumor from the face. That's cutaneous malignancy, squamous cell carcinoma with good margins. We took the specimen, and we did I addressed the neck also. It was an N0 neck, addressed from level 1 to 3, and we did a rotation plasty, raised the whole flap, rotated it over it was like a changeover, and he looked more young on this side of the face then. Coming out to second primary, so this is a very special case. He was a case of CA right buccal mucosa. He was given RT stage T1 N0, and after a few years, he developed ulcer-infiltrative lesion with respect to right side of the tongue, and so we call it a second primary. It's again a very big topic to discuss. He underwent composite resection, wherein a hemiglossectomy was done. Part of the floor of the mouth was taken, and segmental mandibulectomy was done. The reason for doing segmental here was we can see it's an edentulous mandible and pipe stem mandible. It's unsafe. It's very hard to get away with just doing marginal. And I took a PMC flap, pec major was taken. You can see the radiation skin changes that is there post RT, which was given for his buccal mucosa. So that's the new tongue that we had created. So which are the cases wherein, so now you have done the surgery, you've got the HPR, you have got the pathological report, you have the P stage with you. Now, which all patient need adjuvant? Adjuvant is any kind of treatment that is given post the primary treatment. So the indications for adjuvant RT, when it comes to primary, all T3 and T4 should receive adjuvant RT. Deep infiltrative tumor may be a T2 with a DOI more than 7 or 5, whatever your institution protocol is. High grade, poor differentiation of the tumor. Perineural invasion, lymphovascular invasion, worst pattern of invasion, that is from type 4, type 5, tumor budding, positive margin. Positive margin is an indication for giving CTRT and not just RT. You have to add chemotherapy to it. What do you call, I forgot to add a slide on margins basically. What do you call a clear margin? Any pathological margin or a microscopic margin that is more than 0.5 centimeter is treated as negative. Anything 1 to 4 is treated as closed or labeled as closed. And the positive margin, the standard definition is it should be less than 1 mm, or there should be tumor at the margin, carcinoma in situ, or severe dysplasia at the tumor margin are considered positive margin. It's entirely, at times, mostly it's a surgeon's fault. It's not an oncologically safe surgery to come out with positive margin. That's the reason we should have frozen when we apply oncological surgeries in our institutes. Coming over to lymph node, N plus disease is an indication for adjuvant RT, though still there's a international controversy on N1. It's still not clear. Studies are down the way. We might get a clarity very soon whether N1 should receive adjuvant RT or not. But the protocol that we follow in India, most of the institutes, for N1 disease, we do give adjuvant RT. And then extranodal extension, as I said, again, a very bad feature from the lymph node. You should give chemoradiotherapy and not just RT. This is a landmark paper which we all need to know. Bernier and Cooper trial, we call it. This is the paper EORTC. There were two groups, EORTC and RTOG. And this laid the foundation for giving adjuvant CTRT, or cleared the guideline giving adjuvant CTRT in oral cavity patient. Adjuvant CTRT should be given for positive margin and extranodal extension. So with that, I come to an end. Thank you. Any doubts?
Reggie?
Yeah.
Thank you, sir, for giving us an insight into oncology. I would like to ask one question. How should we go about verrucous carcinomas when they are adjacent to the bone?
Verrucous carcinoma, very good question. It's a very tough clinical decision when it comes to verrucous carcinoma. How I was taught and what I do in my practice is, if I come across a verrucous carcinoma, the problem is, first you should learn to define a verrucous carcinoma. Many a times you will not see invasion. It will be a proliferative cauliflower component that is there, and it will be difficult for the pathologist. You will be fighting with your pathologist. So can you see any invasion? Unless and until they see an invasion below the basement membrane, it is very difficult for them to call it an invasive squamous cell carcinoma. So how I go about it is, I give them an option. I will treat your primary, and the primary should be dealt with safe oncological margin, how you would approach a squamous cell carcinoma. And maybe you can give the option of neck dissection to the patient in the first sitting itself, or you can tell the patient that let your primary HPR come, and based upon that, in that, if it comes out to be squamous cell, I'll treat your neck at a later sitting.
Okay, sir. Thank you so much, sir.
Anybody else?
Good morning, sir.
Good morning.
In the slide, you were discussing the depth of invasion versus the thickness. You were explaining about
Yeah,
some lines. Can you do that again once?
Okay, fine. I'll do that once again. It's a very important concept you need to know, and mostly asked in your fellowship exams, in your entry and exit exam. So when you talk of a tumor, we have two kinds of tumor. One is a ulceroproliferative tumor, where you have a big proliferative component. And then the second is an ulceroinfiltrative tumor or an ulcerative tumor. So when you talk of an ulceroproliferative tumor, all these times we were just taking into the literature, just spoke about the tumor thickness. But these days, it's not just the tumor thickness that we see, the depth of invasion that has been added into the AJCC 8th edition. How do we calculate the depth of invasion? We draw a horizontal line from the adjacent. This is a normal mucosa. Just a second, let me share my screen. Is my screen visible?
Yes, sir.
Yeah. So So all this while, all these times we just spoke about the tumor thickness. How to calculate the depth of invasion? You draw two lines. These lines have their own names for academic point of view. The horizontal line is called the horizon. This is the horizontal line. The horizontal line is drawn from the adjacent normal basement membrane. This is the normal mucosa that we see here. And then we have a vertical drop down line from to the most infiltrative point of the tumor. And this blue line, this is called the plumb line, Plumb, plumb line. And this is your DOI. This is your DOI. And now you can see here, this tumor, the tumor thickness will be more than the DOI. What I am concerned is not about this component, whereas I'm concerned about this component. If you ask me, this tumor, this measurement is the one that gives me or is a prognosticator for me to decide on the management and the prognosis of the tumor. Whereas when you talk about an ulcer-infiltrative tumor, where you don't have a proliferative or a cauliflower-like component, you have the horizon, again, from the adjacent basement membrane, you draw your horizontal line, and then you have a vertical drop-down line to the most infiltrative part of the tumor, and that's your plumb line. So these tumors here, if you calculate the thickness, it would be less than the DOI, and these are more dangerous than the proliferative tumors. Was I able to clear your doubt?
Yes, sir. Thank you, sir.
Any doubt is online, somebody's. Anybody from the alumni has any doubt, they can ask now. Anything?
It's either clear or all clearer.
I can see fellow oncosurgeons, Dr. Aby K.
Yeah. Abhipsha was my junior in Malabar Cancer Center. She would be completing this Feb. Abhipsha, are you there?
Dr. Cami, you can share your experience in Papua New Guinea. Dr. Cami.
Yeah, hi.
Hi.
Yeah. I mean, before I share my experience, I really don't have anything to say. But I just wanted to ask Dr. Aby, how often are your cancer patients with a combination of betel quid chewing and tobacco? What's the percentage like?
So yeah, I would just talk about the northeast of India. According to the international data that we have, the highest incidence of tobacco chewing is maximum in the northeast part of the India. So it's quite frequent here. It's not just males here, but anyone that has oral cavity cancer has this habit. And for me, it's most of the females that I've encountered. If you go through my database, it's mostly females and less of males, and I'm quite curious about it. But it has a strong association with the incidence of squamous cell carcinoma. Tobacco in any form, whether it be smokeless or smoked tobacco.
Other than tobacco, betel quid or pan, gutka?
When you talk about tobacco, it's again a very big topic. The various forms of tobacco, various constituents are there, and carcinogens are different. Betel quid, yes, but lesser to the active tobacco form of tobacco.
Okay, thanks.
Betel quid, I would contribute more to a SMF, and then you can have a component, maybe an erythropoietic patch, which might progress to squamous cell tomorrow.
Okay, in Papua New Guinea, we don't have chewing tobacco at all. It's mostly just chewing betel quid and smoking tobacco. So that's an interesting thing to know. Thank you.
Anyone who has a habit, it's important you screen them on a regular basis.
We were having with us, they are not there now, but we had with us Dr. George Kaushi from Oral Pathology Department, Professor and Head. We had Dr. Pamela from Radiotherapy, and I can see other colleagues from Radiotherapy Department as well. Please unmute if you have anything to ask or any comments you have. Okay. So thank you, Aby, for walking us through
Hello.
the. Sorry. Okay. Yes. Yes.
Hi, Dr. Aby. I am Dr. Abraham. I was actually with Dr. Aby when he was doing his BDS course here in the CDC.
Yeah, bro.
It's very nice to see
How are
somebody who
you?
has done well. And it's good that
Thank
you're
you so
coming
much.
back and you're contributing your experience over here. It was a very nice presentation. I especially like that
Thank you so
Angola
much.
part where you mentioned that Kupo paper. That's
Thank you
also
so much. Thank
important
you.
for our residents in radiotherapy to know. Good job
Yeah.
and congratulations on a wonderful presentation.
Thank you so much. Thank you so much, everyone. Hope you're doing well.
ऐनक लगा के बैग लगा के इतनी स्मार्ट हो बन के आई
Thank you, Epi, for walking us through this evidence-based management of oral cavity cancer. It was really informative, and especially the series of operated cases that you showed in the end. That shows your expertise also in the field. Thank you for your lecture. I would like to ask Dr. Indrajot, Professor and Head of OMFS, to say a few words.
Your presentation was very nice, and it was an eye opener for all the students as well as for the PG undergraduates, graduates. And I think these kind of small presentations can make a lot of difference in educating and in diagnosing the treatments and giving us an insight about this, what is going on and what is the latest update in cancer. Thank you so much, Dr. Aby, for your nice presentation. And I would also like to thank all the participants who have participated from various parts of the world. Thank you so much. God bless you.
Thank you so much, sir. Thank you so much, sir.
Okay. So with this, we are concluding today's webinar. Hoping to see you for another webinar series very soon. Thank you, Dr. Aby. Thank you.